So I go to see the radiation oncologist. She was very nice. She had a lot to say, and there was a video as to how you'd be doing your radiation, what that looks like. So she goes over all the different things that could happen, and if she had a sense of humor in the middle of her explaining all the different side effects, because at this point I've had it. Every time I go in to see a doctor, they're like, you know, you need to do this or whatever it is they're telling me about. But they're like, but you might have this might happen, this might happen. I mean, it sounds like those commercials, right? And maybe even death. But like I told you, I think I told y'all, but the chemo pamphlet that they printed, you know, with the side effects for the drugs, instead of starting with the small stuff, like you might be nauseous, you might have a rash, you know, instead of starting with all that and ending with death, every one of them started with, you may die. And then went into smaller stuff. Because I didn't even keep reading. I was like, look, if you're starting with death, I do not want to know how this finishes. I don't want to know. Like, I can't imagine what's worse than death. I got it. I get it. I could die. Thank you. So, don't read the chemo pamphlet. They give it to you. I'm like, why would you give me this? I understand that's a possibility. Don't read it. So anyway, so she's reading radiation side effects. She's like, look, we're gonna hit your rib. So if you have left breast cancer, your heart's kind of in the way. You have the top of your lung gets hit, so it's gonna get scar tissue. But in your reserves, and I'm like, well, maybe I want my reserves. And of course, my husband's like, honey, are you gonna be like an Olympic athlete? And I'm like, I might. I don't know. And he's like, I hate to tell you, I think that ship has sailed. Truth hurts. Truth hurts. But he's right. I don't think I'll be using that reserve part of my lungs. So that's okay. They hit a rib that's up at the top. And so that could break periodically. Sounds like fun, right? Lymphedema. Big chance of that happening, 10 to 15%. Then she said, you know, you might have pericarditis, but that's curable. So I was like, okay, because, you know, they might get the edge of your heart, stuff like that. And then she kept saying, she's like, oh, you're fair. Oh, you're so fair. And I was like, this is gonna hurt, isn't it? And she's like, yeah, your skin may have, I'm gonna say boils, but she essentially was saying boils, but like burns, bad burns. You blister. These are all things that could do. Skin breakdown. I was like, what exactly do you mean skin breakdown? Because I had learned the breakdown word with the breast surgeon, because underneath your breast, there's like, you know, area where things kind of start to break down. Where the skin broke down, and you gotta try to get it to heal back, and there's weight on it. So I don't know, they kept calling it breakdown. And she goes, no, not like that. She goes, have you ever scraped your knee? And I was like, of course. She said, like that, but in all your creases. Like your armpit, the creases that would be radiated, your armpit, under your breast, things like that. And I went, that sounds fantastic. Anyway, if she had had a sense of humor, I would have taken the clipboard, because I was signing off that I was okay with all of these things. I would have taken them and been like, well, thank you for your time, and set that down. Because there's just this laundry list of things that, you know, may or may not happen. She drew pictures, and, you know, this percent of this, and this could happen, and that could happen, and there could be nerve things in your shoulder, and, you know, you could, you know, you can mess with the implant. You can have capsular contracture, where, you know, an implant's pushing out and your skin is contracting with the radiation, and it kind of squooshes the implant, and that's hard, very uncomfortable. You gotta do something about that. And then she's like, and you may lose the implant. She said it like it was a child, and I was like, look, we just met, me and the implant. I mean, I'm not that attached. But what I found out though is it's also very hard to do surgery post radiation. It can be done, but it depends on your skin health, because some women have tried to fix an implant post radiation because of radiation, what it's done to it, or whatever reason, and the skin was not in good health, didn't heal, and eventually they don't have any implant at all, you know. So there are things that can be done, but it's way less flexible if you get radiated. But that's, I mean, it's a reason if you're young like me, because you have a long life of not being able to have surgery in this area. The skin is just all going to be different because radiation changes your DNA in the cell, and that just kind of damages things. When we left her, I was like, "How do you feel, Thomas?" And he was like, "I think you should do it." And she said it was. Oh, let me back up. She said it was in a gray area, and then I could decide. And I said, "What would you do?" And she goes, I wish I could tell you, but I don't know. I'm in a gray area because, as I've explained before, the different types of cancer and the different treatments with neoadjuvant, adjuvant, stuff like that. For those of us that have neoadjuvant treatment, meaning before surgery treatment therapies, if you go to surgery and you have a complete pathological response, like I did, that is the best outcome. But also, they don't have the data to say, okay, well, you still need radiation. So they have, once again, they have a study out, but it won't be back anytime soon. But they have a study out because I think, the best minds in radiology, I would assume they're not doing that study with the thesis because they thought it wasn't true, because they wouldn't put these people at risk who are going through the study not getting radiation to see if they in fact don't need it. So with people who had a complete response, they don't know if it's necessary or not. So it is a gray area. But they will tell me that there's still breast tissue left, anywhere from, somebody said 7% or whatever, 5%. And somebody said 15%. I mean, they're picking random numbers. Nobody really knows. They are guessing. I mean, my surgeon said she gets everything, but between 2 and 3%. I mean, she said she was going to get everything. But I guess there's breast tissue in places they're not actually going. There's some breast tissue. And they're not going to be able to see every cell. And so there's a range. It's an assumption that there is still breast tissue there. So it's like, radiation is only for local recurrence. So the question is, what percentage of a local recurrence do we think is going to happen? Like, what are the odds for recurrence locally? And this lady was saying she thinks, 10 to 15% chance. Well, that's kind of high. And she said she could get it down by about 3/4. So I'm thinking, okay, we do it. So I went, had a simulation. And at this point, by the way, everybody has taken photos of me and my breasts. There was a lot of photos with plastic surgeons before and after. It was just like on TV where they mark you up and write on you with a marker, and he's measuring things. And then there's a lot of post-op photos, and every doctor I visited was trying to see everything. So, there's a lot of, I'm like, you didn't get my head, did you? You didn't get my head. But at these things, they take like a good old-fashioned camera. I don't think it had film. I think it was still digital. But they're like, we need to take your photo because they got to reposition you in the exact same spot, right? So they're taking you from every angle with your hands are up like this. And you're just laying there, and they're just taking photos, and you're just like, something I swore I would never do. It's not very boudoir pick either. You're in fluorescent lighting on a metal table. It's not exactly ideal. So they did all this measuring, and I didn't know it, that this planning session was also where they tattooed me. So they gave me 7 tattoos. 7! Now, they call them tattoos, and I think that's just so patients know that they are permanent, because they are not given like a tattoo. A tattoo is like a scratch on the surface. These were subdermal. So they took a needle, went under my skin, wiggled ink out, and then pulled it out. And so good news is they no longer do black ink. They have mine's pink fluorescent, so it's pink, and let's see this dot right here. Don't know if you can see it. There's a very tiny one there. That's one. One in the center one, which, by the way, they found the only place on me that has 0 fat. And she had to do that one twice. She had to do 2 of them twice. Because she goes, oh, there's not enough ink. She has like a little light to see. The one on my, like, going towards my stomach is really bright. I've got 2 on this side, 1 on this side, and 1 on my arm right here. So she put a whole bunch, and I'm thinking, well, I don't have a choice in this either. And it was not comfortable. I thought it'd be like a tattoo, and I was like, that's not gonna hurt. It's such a tiny one. No, it was an injection of ink. Anyway, so they do all of that, and that's so they line you up in the machine every time perfectly, so they radiate the exact same area over and over again. So most of your appointment when you go to radiation is lining you up correctly and positioning you. So then everything goes to this dosimetrist, which we learned was a profession. Who knew? A dosimetrist. And they do all the calculations and plotting and everything based on your anatomy, because they put you through, sorry, let me back up. The simulation that I did is basically a CT scan. And you go through the CT scan as if it was radiation, and they're imaging to see what my anatomy looks like, what the path is that they're trying to go to, you know, the area that they need to do, where the lymph nodes are for me, all that other jazz. And I do it with and without a breath holding technique. So I had to hold my breath for 30 seconds. Not great. And they have you hold your breath. And they give me a button. And they're like, but if you really need to breathe, hit the button and then breathe, because they'll have cut the thing off. But I feel like, I was like, shouldn't I hit the button, give them a few minutes, and then breathe, so they can cut it off? She's like, no, they'll hit it right away. And I'm like, what if the person's not paying attention? What if they're getting a cup of coffee, and next thing you know, sizzle right through my heart? Anyway, so I didn't love that. I managed to do the breathing okay. I get out of the simulation, and that same doctor who was kind of wishy-washy initially, she wasn't overly confident, because she says gray area, so she didn't know. She was like, she kept saying, you know, well, I don't know, because you're young, but you're not that young. And I was like, okay, all right. Like, I'm young for breast cancer. I'm young for a lot of types of cancers. But I'm not young in life, I guess. I'm not really sure. But, so it's kind of with the benefit, with the risk reward analysis, there's a long-term effect for quality of life for somebody my age, and with the side effects of these things. So anyway, but she got there, and it was like a grandma, like she's an older lady, and she was just like, well, I don't know. She was lovely. She was like, she came in, it was not an appointment, and she was like, I just want to make sure you're comfortable, and are you sure? Are you sure? I just want to make sure you're sure, because I mean, you're young. And I'm like, well, are you not sure? Because I thought you said either way. I mean, she made it sound like either way, but she sounded like she was leaning towards definitely do it. And then it was a lot of, I don't know. And I was like, well, if you don't know, I don't know. So I tell my oncologist, my chemo oncologist, when I have an infusion, and she says, hey, you know, if you want to get a second opinion, I mean, this is your life, you know, here's the name of somebody. So I go to Sibley Memorial, which is a Hopkins hospital. I go in DC. I see the lady she recommends. That lady had more research, more studies about different things. And I was like, that makes us feel better. And then I was like, would you do it if you were me? And she actually gave me an answer, because I always ask this question. I just, you know, in case they answer it, I'm not going to hold them to it. I'm not making them sign anything. But if you know everything you know, and you're the hammer in this field, right? You know, and everything's a nail. If you say no, then that holds a lot of weight with me. Well, she was like, no, I wouldn't do it if I were you. She said, unless it was going to keep you awake at night, that you didn't try, that you didn't do everything that's out there that's available to you, I would not do it. So I was like, okay, that's good. So then we figured, okay, we've got 2, but it's not conclusive. So I was like, let's do best 2 out of 3. And she had mentioned the other place that had proton therapy. So she had proton therapy. She didn't think proton would be better. But I went to the other place because they had both, and I just figured, so I went to University of Maryland Medical Center, which is a research hospital. So the first place, by the way, is a breast center that's highly reputable in Annapolis, and that's where my breast surgeon was. So just, you know, for those of you taking notes. So